day and welcome to the COVID-19 GP Preparedness webinar hosted by Nikki Kanani. My name is Katrina and I'm your event manager. During the presentation, your lines will remain on listen only. If you require assistance at any time, please key *0 on your telephone and a coordinator will be happy to assist you. You may submit web questions throughout the presentation by clicking on the Q&A tab, typing in your question and send it to all panellists. I would like to advise all parties the conference is being recorded for replay purposes. Now I'd like to hand over to Nikki. Please go ahead.
Hi Katrina, thank you so much, and thank you everyone for joining us despite, for many of you, late notice and extremely busy pressing schedules. I really appreciate it. I'm joined today by Ed. Ed, do you want to introduce yourself?
Hi, Ed Waller. I'm the Director of Primary Care Strategy and NHS Contracts and the Lead Director for Primary and Community in the COVID response.
Lovely. And I'm Nikki. I'm a GP in South London and Medical Director for Primary Care at NHS England and NHS Improvement. So we've got quite a lot to get through. Last week, the PM distracted us slightly and took us off course slightly. So although he is due to speak at some point, I'm going to just press on to take us through some of the key things that are going on, both in terms of what's happening nationally, what is happening in terms of guidance, clinical and operating guidance, how we're going to try and make things as straightforward for you, and then focusing a little bit on digital, what's coming up in the future, and then taking questions. In the Q&A bar, if you can write your questions, we'll try and pick out as many as we can. We had a webinar last week and we used a slightly different infrastructure and it's taken a bit longer to get that online, but from this one we'll be able to get it online after the weekend, so please do look out for it. It will all be on the NHS England Coronavirus Primary Care site and we'll put up the details at the end. Can I start off by saying thank you? You are incredible. You've been working tirelessly. I know it because you've been telling me and I've been seeing it, and it has been utterly overwhelming. We are in a completely unprecedented time. We are all learning and trying to do the very best we can in a really difficult time, both personally and professionally. We're worried about the people we love. We're worried about what's happening in the country. We're worried about our practices. And it's difficult. I think, it's difficult for us. We're trying really hard to keep up to date with the announcements and the guidance and the strategy. And sometimes we're not communicating as quickly as we want, and we're trying to rectify that. I know it's having an impact on all of you, and I just want to say thank you. We all want to say thank you for your time and your dedication, and really appreciate that. So, we've had a number of announcements since PM spoke last Thursday and we last had this webinar, but overarching that is a change in case definition and a change in strategy. And you all know it, so I'll whiz through it very quickly, but it's a cough or temperature over 37.8, and that means then you are self-isolating in your house, as are your household contacts. There is a lot more detail on the website as to when that differs. So sometimes you're isolated for 7 days and sometimes for 14, and that depends who else is in the household and when you got your symptoms as well. And also, the Prime Minister announced wider social distancing initiatives to try to suppress the spread of the virus as much as possible. So all of us will be finding ourselves in different life scenarios, really avoiding doing things where there are lots of other people around. Specifically, he also mentioned that for our very at-risk, our high-risk individuals, of which we think there are about 1.5 million, we will need to take a completely different strategy, which is something called shielding or cocooning or protective quarantining. Different terms are being used. And that is a group of people who will have to stay inside almost exclusively, which is really difficult for them physically and emotionally. They will need to stay inside for anything up to 12 or more weeks. So we've got lots of things happening, models of care, ways of working, shifting. When I talk about the immediate term, I'm talking about today and tomorrow. When I talk about the medium term, I'm talking about next week. And I think it's really difficult to predict what general practice and primary care looks like in the coming weeks. but we're going to try and do our best. So just a bit of an update. We know that as of yesterday, we tested just over 56,000 people. 53,000 were negative and 2,500 were positive. And sadly, we have crossed 104 now people who have sadly died from coronavirus. It means there is a huge pressure on all parts of the system. I think this is not just general practice or 111. We know, and we'll all have friends and colleagues in the acute sector who are feeling this as well. The pressure is enormous across the system. And so Prime Minister, again, made more announcements yesterday, closing schools and advising us to really take this seriously and make sure we employ all social distancing measures that we can. So what that means is that, first of all, if we try and think about this in the context of the NHS as a whole, I do urge you, if you haven't had a chance, please read the letter from Simon and Amanda earlier this week. That sets out really key actions that we're asking the whole NHS to do. And the reason that we're trying to look at it as a system is because we have to be one system in this. There's no place for us to be in our individual spaces because we don't have that ability. We need to free up our critical care capacity, which is, certainly strained in many parts of the country already. We need to prepare for the huge numbers potentially of patients who will need respiratory support. Really important, we need to look after our staff and maximise their availability, and obviously the Prime Minister's changing case definition does apply to staff, so we need to come back to that. We need to all play our own role in the wider population measures that have been announced, and we need to try and remove routine burdens so that we can do all of those things. And we'll come on to that in a minute. Before we come on to the detail of the kind of the shifts that I think we're going to start to see, I've got Amy on the line, and Amy has been coordinating colleagues in RTGP and other clinicians to update our standard operating procedure. Amy, could you just tell us a little bit about what's happened to the standard operating procedure since it was last updated?
Yeah, of course. There's quite a lot of changes, so I can just run through those quickly for you. We've had to rethink things a lot in view of the new possible COVID-19 case definition. And broadly, our response to that is that people who meet the case definition should initially be directed to the NHS website, to the government advice on staying at home, and should use NHS 111 online where at all possible for urgent health concerns, only using the 111 telephone service if that's really necessary. From a GP perspective, we strongly recommend that all patients should be remotely triaged before face-to-face appointments are made. And we'd like to encourage practices to move towards remote consultations wherever possible. If following a remote consultation either by the patient's GP or by NHS 111, it's felt that the patient needs a face-to-face assessment, then they need to be seen either at their home or in the practice using appropriate personal protective equipment, and that equipment, that the PPE needs are detailed in the online guidance that PHE have produced. In terms of a kind of summary of an approach, we want to keep patients with possible COVID-19 away from people who don't meet those criteria as much as possible, and there's various ways that you can try and do that. So kind of in terms of the timing of clinics or in terms of the spaces that you use for these patients. And whilst we've outlined how you might make this work in your practice, we're really keen that practices start thinking about how they can work together to do this over a wider footprint using PCNs, and how they'll need to work with pharmacies, community services, everyone else in the community to make the system work as best as possible around patients going forward. We recognise that we're moving towards a situation where you're all working under increasing pressure, and the more that we can sort of streamline things for patients and to protect staff, the better.
Excellent. Thank you, Amy. So please do look out on the website on that link. The SOP will be on there. Katrina, a few people are having difficulties getting the audio to work or to dial in, so I'll just ask you to keep an eye on that while we carry on.
Okay.
So I think as Amy's described our kind of ways of working, I find it helpful to think about 3 cohorts plus staff. So we will continue to have people on our registered list who are urgent, non-COVID, who need care. We will have people who are COVID probably positive, and I'll come back to the probably, who will need care that aren't suitable for hospital and that will need our help. And then we will have our high-risk individuals who are at home. And we need to start thinking about care in those 3 categories, and we've asked CCGs to start working with yourselves to plan for that, because it's going to be really hard to do this at a practice level for your own resilience as much as anything. So starting to think about how you work over maybe your PCN, maybe your neighbourhood, and we'll come back to the kind of the PCN requirements, which we're sort of stepping away from so that you can just work together on your COVID response. But with your CCG really coordinating that function, and then maybe describing a hot or cold site, a respiratory clinic, or for some, and in some patches already, a home visiting service over a wider geography that is able to look after patients that really do need a visit. The 4th cohort that really underpins it, that it doesn't work without, is obviously our staff. Now, currently, our staff must follow the same guidance because it is right and appropriate that they follow the same guidance that has been set out in the initial case definition by PM and then by our Chief Medical Officer, Chris Whitty. So staff who are at high risk will necessarily be asked to shield and cocoon, and you will find over the next few days staff members who are in those categories, and we need to think about how to look after them, and Masood has some ideas, so we'll come back to that. We will find staff who are more vulnerable, and this is the time to together across the geography say, well, actually, 5 or 6 of our staff have long-term conditions that will make them more vulnerable. Can they be doing our cold sites or our remote care? The 2 things that then fall out of that are, number 1, testing. Now, testing is one of the most common questions I can see even now. Testing is one of the most common questions. We have had to work really hard to secure the kit and the reagent in the numbers that we need. There is nobody who does not want staff to be tested. Any single part of government, DH, PHE, our organisation, wants staff to be tested, and within that, general practice staff are essential staff. So that will come online, and that will ramp up now quickly that we've got the testing kits in place. So that is going to happen because, of course, that means you can get more staff back to work. That also means that you need to have enough PPE. We are spending the next 48 hours making sure that the health services it gets the PPE that it needs, the personal protective equipment. For primary care, that is still the face mask, the apron, the gloves. And for now, with updated guidance in a few scenarios, eye visors. So we're adding those to the packs as well. The masks are the masks that you got. I know there was real anxiety that those masks had the labels stuck over. So this is a little bit like pat testing electrical equipment, as somebody said. They get stress tested, and if they meet the requirements, they get another label on top. I have reflected with NHS supply chain that it would be good to let us know that so that we don't worry about the kit that we're getting. Online, through that link, you'll be able to find advice on where to raise other PPE type issues. So whether that's hand gel or paper towels, etc., you'll be able to raise it through a telephone number and email address. That's available through that website. Okay, just a note on key workers, because obviously we all rely on our staff, each other, to work. So we have submitted, I hope, the list of key workers that will make the most sense. And so in NHS terms, that is, of course, all of you, so general practice and people who are called to that COVID response, and for pharmacy, pharmacists and those who are there to ensure pharmacy can stay open as a registered pharmacy. So I know some people are having difficulties with schools, and that is a conversation with schools, so you are on the key worker list, and it's important that you know that. Okay, so we've talked about a lot, in terms of change and the things that we're going to have to do in general practice. That doesn't happen unless we do 2 things. One is free up your capacity, And it was, busy enough before this all happened, wasn't it? So you need to free up your capacity. And really importantly, as independent contractors, we need to protect your income. So I'm going to hand over to Ed and Stephanie to talk a little bit about what's in the letter and what that really means for you, particularly in general practice, over the next few months or longer, if that's the case. Ed.
Thank you. It's probably worth saying that there have been a few questions on the bar so far about when the new SOP is being released. As we've been on the line, I've seen it go into the cascade process. So it should be coming out as we speak and go up on our website really soon. So I hope that helps people. First thing to say is, again, to echo Nikki's thanks for all your hard work. What we've tried to do on the contract side is essentially to facilitate the freeing up of capacity in practices in order to respond to the extra work that we know COVID will bring you all, whilst protecting income, because we know that needs to be done, and it needs to feel clear. So what we've tried to do in the letter is be clear about that, but I will go through some of that in more detail. There are basically three types of action that we've suggested and will take forward. The first are a series of things about how we'll free up capacity by taking national action. The second is a list of permissions, in effect, to stop doing things at local level, to make the time that you need, with a guarantee that won't affect funding flows. And the third is an instruction to local commissioners that they should effectively mirror those first two things. This is a set of changes that will be in operation until we change them. We would revoke these at the end of the period for which we think COVID is going to cause additional workload. We know that will be for some time. And there are still some options to add to this list if we need to, where we want to keep as much going as we can of the core general practice work, and there are a few things that aren't on this list, but we could come back to those if we really needed to. Importantly, to bring all of this into force legally, there do need to be some changes to regulations and other parts of the contract and legal framework. Those will come in as soon as they can. In the meantime, you have our commitment that this will not be enforced and that commissioners locally should not take remedial action under the contract on all the things that we set out here. So just to run through what the contract letter describes, what the letter describes in relation to the contract, we're effectively saying that on QOF, we will let the QOF 1920 run happen, but any practice whose 1920 performance is less good as a result of having to divert activity for COVID will be paid the 1819 payment that they earned as a default, and that gives people guarantees of at least the 1819 payment, if not a better one if that was what they earned this year. We will protect QOF income in 2021 as necessary, and we're having an ongoing discussion with the BMA about precisely how that will work. Obviously, the last time we made a QOF payment for some, like a proper QOF run with a full year of normal activity will now be for the 1819 year. So the discussion we need to have with the BMA, given that things change over the years with QOF, is exactly what protection in 2021 exactly looks like, so we can give everybody clarity. There are a number of changes around the network contract, so it's important that the PCN DES does exist next year so that people continue to get the funding flows in that PCN DES through to the practice. In particular, the money that the additional role scheme has been paying to practices for recruitment they've done will continue to exist. We accept that practices will, if they're able, do extra recruitment in the scheme, but even if they're not able, they still need the money from that scheme to pay for staff they've already recruited. And we have already said that for the first 2 quarters of next year, we will defer the introduction of the Investment and Impact Fund, which is the new incentive scheme at network level, and make the payment of that money to networks so that it isn't lost to them. The network contract DES workforce return process is all pushed back. The service specifications are pushed back to October for structured medication review. And we have said very clearly that although we would like very much if networks can make progress against some of the early cancer diagnosis work that the network is going to bring in, if COVID work intervenes, and that will be accepted as a reason why that has not happened. Appraisals and revalidation. Appraisals we suggest should pause. Revalidation advice was issued today effectively to give people more freedom and to reduce the burden, and CQC have already made an announcement that their inspection routine will be suspended. And then there are a series of things that we list where we are giving flexibility to practices to cease this activity as they need to prioritise. So new patient reviews, over 75 health checks, annual reviews, routine medication reviews, frailty reviews, and all of the work around the friends and family test and PPGs are just some of those examples. And then finally, as I said at the beginning, any instruction to CCGs that LESs, LISs and local pilots should cease. We will also be ceasing national pilots, and that the funding should flow to practices as a default. The only exception to all of that would be if it's mutually agreed that local enhanced services would aid the response to COVID. So, for example, if there is a care home service in your CCG that could help support both the workforce and the response to COVID, then we might expect that to continue in place, perhaps in a slightly modified form. That's all I was expecting to say, Nikki.
Thank you.
Come back in at the end if there are questions.
Lovely, thank you. And you know, I know it was frustrating we couldn't get that massive list out as quickly as we'd like. There were legal, contractual, financial implications that we just had to make sure were sorted, so that then you have the security to move on, focus completely on the clinical care you need to deliver, and know that we've got your back, and that was really important. Can I just mention a couple of things that have come up before I bring Masood in on the digital end, because obviously the digital side is critical. There are a few questions on PPE. As I mentioned, PPE is coming. I know some of you are running out quickly. The standard operating procedure sets out when to use it. We do not expect you to see patients that you consider to be COVID positive without having PPE, okay? So we are not sitting here wanting you to put yourself into any uncomfortable positions, and we're working as hard as we can to get the country the PPE it needs. On staffing, and I should have talked about this first up and early on, and we'll come to it a bit more, locums. So, Ed, when we come to talking about workforce more generally, let's pick up what we're offering, or trying to offer our sessional colleagues. And then on key workers in schools, quite a few questions, which I understand it is worrying. I'm trying to sort out my own childcare at the moment, and it is the whole general practice team. We know that you can't run without your wider team, and please know that we've mentioned that. We have got a lot of very, very specific clinical scenarios coming up in the chat box. I think we'll struggle to answer very specific examples. I know you want those answered. I think there's two things. One is that I really want you to be able to use your clinical judgment and know that we and the national regulators support you in using your clinical judgment. And secondly, we're working closely with our CGP, who are developing, as we speak, and hopefully they'll have a lot of it live this week, a specific scenario-based guidance to help you work through some of the more tricky clinical scenarios that I know that you're facing. So, Masood, we're going to be facing all sorts of different scenarios, as I mentioned. What does that mean for us in the digital space?
Thank you, Nikki. I think the critical things I want to try and get across is that as we move rapidly, almost overnight, to a point where actually we're now having to consult our patients remotely, from being very used to doing lots of face-to-face consultations to almost everything is triaged, and only seeing patients face-to-face on a case-by-case basis when it's safe to do so. We need to make sure both our patients have effective communication with us and the communication channels we use work, but also that the staff looking after them are comfortable and have all the right tools that are needed. So there's a few things I just need to probably call out in this bit. One is that people are always worried about the whole idea of video consultations or information governance in working remotely. Last Friday, in conjunction with the Information Commissioner, and the National Data Guardian, we made sure we issued some really simple guidance, which actually allays lots of people's fears about getting into trouble with the Information Commissioner or the CCGs or other bodies about doing video consultations or tools they were using or even working remotely. So just reassuring that it's safe to do so. I think the critical thing here, and one of the things we called out in the letter that went out today, which is important, is that we do need to be able to communicate with our patients about our change in process. So those who have appointments with us, well, actually face-to-face appointments are booked. We're actually telling them that actually we'll be contacting them and speaking to them first before they come to the surgery, and only asking them to attend if it's appropriate. So therefore, in order to do that, sending text messages out, telling them about the change in process so that they can be ready to expect our calls. And as a result, we identified that in some areas there were some caps on text messaging, other areas that were unlimited. And we worked closely with the central team here and are working closely with the region and the CCGs to make sure there aren't any caps for any of the practices in terms of the messaging that they need to do to communicate with patients. This becomes even more important as changes happen on a day-to-day basis, and we need to tell patients about changes to the way you might be engaging with them. I think the second thing that is the most common request that we're getting is about the how to do remote working. Okay? And I think it's really important because it's something that we're very used to having our computers in our rooms, in our practices, and using them to communicate with patients. There are a couple of scenarios. One is the fact that we now have the opportunity to not only use telephones but do video consultations. And I've heard of really good examples where people think, well, actually, I don't think video will add any value, but I've seen lots where we were worried about children. The video consultation suddenly allayed your fears and reassured you that the child is well. So actually it has helped, and even in some cases with dermatology it's helped as well. The second bit of this is identifying people who, again, for whatever reasons, have to work from home. Either they're in part of a household which is being quarantined, or they themselves are in a vulnerable group who no longer should be attending or working in a practice because they're vulnerable or at risk, and therefore they need the equipment or the ability to be able to work remotely and still support their practice to do so. So we have, again, with the regions, and it varies area to area. So lots of what we are finding is it does, depending on which CCG you're in, they have different policies and different ways of doing this, to places where they provide you with a laptop with everything on it, to others where they are very comfortable for you to use your own device as long as they give you a secure VPN token to be able to do this. I have heard of some areas where nothing is being provided, and in the letter we're fairly clear that if that is happening, please contact your CCG, and if they're not sure how they can support you, they can speak to my team here nationally, and we will work with your CCG to make sure that you have the most appropriate solution you need to be able to do that. It is worth highlighting that, as with everything else, there are some challenges with always getting hold of physical equipment. People will see even things like laptops, which we would have thought at one stage were plenty in supply. We are now struggling, mainly due to where they're being produced, and therefore as a result, we are being able to get some, but not in the quantities we'd want to. And I would ask that people do start thinking about the criteria for where somebody does need a physical device or whether they could work using their own device. If somebody hasn't got their own device and you can't get a VPN token, I would suggest that we prioritize the devices we have to the groups who are vulnerable. Having said that, we will be aiming to do our best to try and get the solution available to as many people as possible.
Excellent. So safely trying to use our own kit where possible, saving the hardware we have for those who are most at risk and needing to isolate for extended periods. And again, on the primary care site, lots of information and resources and details of forthcoming webinars, I think, as well. And
I think we're going to be doing plenty of guidance and webinars on how to do video consultations, how to use the triage tools effectively. Because it is important, as the workload goes up, that we have tools that can help us to be able to do it safely.
Thank you, Masood. That's great, and we'll bring you in for more techie questions if we get them. I'm sure we will. So in a moment, I'm going to move on to our workforce and more broadly about how we bolster and build the resilience of our workforce. I just want to mention a couple of things that came out. As I said, the standard operating procedure is now live. I know you're busy, but if you are able to just read through that, that is the most up-to-date information on the flow of patients through the system. remembering that we have 111 online, which will be doing a lot of the navigation of people, and NHS 111, but we know that that service will struggle as much as we are, and we need to, work out how we look after each other a little bit. So to do that, we need more. We need more of all staff types. Ed, do you want to tell us a little bit about some of the groups that we're bringing back in and how we're doing it?
Yes. So some of the details of this will be confirmed in the coming days. But what I think we can say at the moment is we are looking at retired GPs in particular, but there are wider workforces involved in that piece of work. The question is, well, the process we have to go through is getting something out to them, to put them back on the register, and then to invite people, if they're not, onto the performers list, as well as then finding an employer and a contract we can bring in retired doctors back on. And there'll be a variety of places in the system where retired doctors might be able to work. We are expecting that as far as possible that would be, unless they want to do otherwise, remote working, and some of this could easily be done from home. We're seeing a piece of work about locums, so I know that some of you have expressed worries about locums status around sick pay and death in service benefit in particular in this period. We know that there is going to be more than enough work for locums to be fully occupied, and we are looking at both how we can benefits they have, as well as how we might try to match capacity in the locum workforce or people who want to offer additional hours to practices and other settings where they need additional GP capacity.
Thank you, Ed. So that gives a bit of a feel for what's going on at the moment. I think something that's coming through both the questions and our general conversations is money. So, I've paid for a dongle, I've had to get staff in. You can imagine it's really hard. The whole system is trying to work out how to do this and then how to count it properly so that you're not left at financial risk. I suggest at the moment just make a note of it, make a note what you're spending, whether it's through the CCG or you're getting it yourselves, and I know some people have. I know there's some issues with the texting function on some pieces of kit, sending out the text messages, there's some delays and you've had to buy extra credits, there's a whole range of things. So please keep a note of that for now, because I think it's really difficult for us to just to understand what you're spending on if you haven't. We want to make sure you're not left out of pocket, okay? There's a question about part-time GPs or people who have days off or have sessions back that they want to be able to give. Please, yes, please do offer them back locally, whether it's in your own practice, and we will be building that sort of locum pool, locum chambers type model rapidly as well, so that they get the support they need to be able to work with us. We're also asking the same of our trainees. So obviously it will vary as to what level of training they're at, but if as VTS has been cancelled and so as exams, we'd like our trainees back in practice. For some, they'll be ready to see people, whether that's on a cold site or even on the telephone, but for some, they won't be ready for that. So as trainers, please have a conversation with them about how they'll best be able to support your team operating as much as possible. Okay, so they are some of the key areas that I thought it was worth going to. I'm just going to signpost to Catherine to have a think about and start pulling out questions that we haven't covered. Before I go to that, I think just a couple of things that it's worth knowing. First of all, PM didn't say much more than we should manage this over the next 12 weeks. So we'll send coronavirus packing in 12 weeks if we all follow government advice. In terms of sort of the flows through the system, as Ed described, we will have a lot more national communications and messages going out. Somebody had mentioned, can we let patients know that they'll be seen remotely, that they won't be getting the care that they're used to getting, particularly routine care. Yes, all of that's in plan. Some of it's already gone live. Some of it will do over the next few days. People are working round the clock just to make sure that the stuff is going out. And also a wider comms piece on the fact that the NHS is really feeling the pressure of this, and to remind people to be thoughtful about the NHS at this time. And if you haven't found all of the different food outlet deals, please do look out for them. They're small perks in very difficult times. So I was just going to talk a little bit about the things that are going to come next, and then I'll ask Catherine and Ed to help me go through some of the questions. So on the most at-risk individuals, somebody asked what happens to them. I'm with the Chief Medical Officer this evening. We will agree a letter that goes out to those patients that have been electronically identified. There will also be a letter from us to you as their GP saying, these are the patients we've identified. Question, do you have other patients that you think should be on this list? Now, obviously, we can't put lots of people on there because, A, it's a very psychologically difficult process to go through, but it's also a huge potential amount of work for yourself. So we need to think carefully about who goes on that list. We may need to have conversations with those people because they are scared or they don't know who, whether to be on the list. And our CGP are developing some tools to help us have those conversations, and they'll be up shortly. So it will be a letter coming to you. They will be automatically coded in your system, so you don't need to do anything to try and make sure the coding's right and everything. They will be automatically flagged in your system. And more details will follow about that shortly. We are developing, in fact, quite rapidly, a really large volunteer network to support those who are physically isolated and cocooned at home. So that includes things like remote volunteering, remote physically distant support, obviously, shopping, getting medications for you, etc. And on that, trying to think about how we can support community pharmacies to survive in this time as well. So whether that is because they've got staff off or because they need to deliver more medications than they had to before. So those are some of the other things that we're thinking about. We'll also be asking your CCGs to work closely with you to start, as I said, to describe what your local model will be. We will have some guidance nationally, but it will vary around the country depending on what your existing infrastructure is, the rate of coronavirus in your patch, the number of staff that are going off, and we'll need local systems to think through what the right solution is. And we want to support that, not get in the way of that. There'll be more advice, as Masood said, on the digital side. And as I said, national communications and more details on how money will flow during this prolonged and difficult time. Ed, before we ask Catherine of any questions, anything from yourself?
No, I was struggling as I was talking to keep up with the things on the taskbar. So if Catherine's done a good job at ordering them ahead, that would be amazing.
Yeah, we do have sort of 500-odd questions, so we're doing our best. Somebody's asking about how volunteers connect into the organisation locally, etc. And Catherine can see all the questions, so don't worry. The volunteers will be linked in different ways, primarily, obviously, through the local government and through social care and the local authority, but also, and very specifically, through where they exist, the social prescribing link worker as well. There are some very loud, well, I call it loud because it's in caps, home visit service. When I described a home visit service earlier, I wasn't saying somebody has to set one up specifically, but I think at a local level, maybe a group of PCNs or at CCG level, you'll want to think about whether you have a home visiting service or you're inviting those people into a cold site where they're safe to be seen, etc. So that is the sort of thing that I'd expect people to be thinking about now. Okay, Catherine, what do you have for us out of the 500 odd questions?
A lot of recurring questions, a lot of recurring themes. One of the big ones is, will there be COVID-19 testing for frontline staff to maintain staffing levels? Will reception and admin staff be included, and how and when will this be done? Okay, yes. So you are, you heard it here first, you are key workers. General practice, pharmacy, people needed to keep each of you open are our key workers. So it's really important that we that we recognise that. So then as the testing comes online, you'll be priority for testing and also for schools and anything else that is set up around our key workers. Something that did come up that I didn't touch on, I'm sorry, but was the repeat medications issue. Look, we've said in both the GP and the pharmacy letters, please, if you're going to
please set up electronic repeat dispensing if you can. If you need some help, we'll offer some technical help, but please set it up. And please try and move as many people as you can onto 28-day scripts, so 12 times 28, where people are on a stable medication. So that gives them the year's supply on repeats, easily dispensable, but without messing up the supply chain. If you put people onto 2, 3, 6-month prescriptions, we're going to have real stock issues. So please put it down on your electronic dispensing as 12 times 28. Thank you. Other questions, Catherine?
The question about, I think there needs to be some clarification on who qualifies as a key worker. Does that include admin and reception staff?
So Ed, you've been doing some thinking on this amongst everything else. Do you want to just set out the key worker philosophy again for us?
So we have submitted our view on key workers to include general practice staff, basically, and also to include staff that are important to open pharmacies. And so, we wait to hear whether there's going to be a formal statement on who are key workers, but that is our view, Nikki, and mine anyway.
Thank you. We've got quite a few questions on childhood IMS, SMERS screening programs. Ed, did you want to just talk a little bit more about those specific services?
Yes, so childhood IMS we would like to see continue. It's really, I think, important that we don't, as part of rising to the challenge of one disease, see ourselves in a position where we have measles outbreaks and things instead. So we want childhood immunisation to continue, and we have also at the moment left screening services in the list of things that should continue as well. As I said, there are options to add to the list of things that we suggest people cease. We will keep our eye on that. We're very happy to have discussions. We've been clear with that with the BMA about what the right moment is to add to the list. Published, and we will, under the changes to the contracts and regulations, have the power to add to it if we need to. Were there any other specifics? Sorry, IMS screening. What were the others?
I think that was it. Thank you, Ed. I think would it be helpful to Ed while you're speaking, just to clarify the medication situation? So people are saying, it's a lot of work to change scripts. Is it necessary? And I think we really do need to stress our medicine supply protocol here.
So there's two things really. Firstly, what we're saying is that the GP contract already says that in an ideal world, people are suitable for electronic repeat dispensing should be put onto it. We do understand that there's work involved in that, though we think it will save people work down the line. The important thing, the really important thing, is that people aren't giving patients, 6 months supply of medication in one go now, because we don't have the medicine supply chain will not be able to cope with 6 months worth of medicine supply dispensed within the week. And so what will happen if that is what everybody does is that some people will actually struggle to get any medication at all to fulfill those scripts. So whether people go on to ERD, which we'd like them to, if that can be done or not, the very important thing is that people maintain the same duration of prescription, etc., in their prescribing patterns for now. And that would help us make sure that everyone gets the medication that they need, because the supply system will be able to deliver it as usual.
Thanks, Ed. Another thing that's coming up is about extended hours and extended access. I mean, what we're trying to do in a patch and geography is sort of consolidate care, use the best of our kind of people and place resources to offer the remote care that we've described. Any other thoughts on sort of extended hours and access and how we make sure that we aren't stretching our staff too far? Ed, I was going to bring you in.
Sorry, on mute, sorry. Talking to myself. The extended hours part of the network days is still there. we have had discussions about how we might need to change some of the expectation around hours, and if we did that, making sure that we have the provision to do that in discussion with the BMA and others. But at the moment, we have left in place the requirements around the hours of opening on GP practices and other primary care providers. Again, that's something we, if people have thoughts about how that might need to change, then we are, through the right channels, very happy to talk about it.
Lovely, thank you, Ed. I mean, I think at the moment we really do need to just be making sensible decisions locally. So, with commissioners saying, this is why we're struggling in terms of staffing or access or whatever. Let's just get it right, and then if we need to then change something nationally, tell us what to do. Okay, Masood, there were some questions about using away from my desk, getting the funding in, AccuRx, other systems like that. Can you just tell us a bit more about that, please?
I can, and I think the critical thing is we're really keen to make sure all practices and all staff are supported with the right tools to be able to do this, and so being able to do video consultations or communicate with patients. But having said that, the critical thing in all that, the right tools, is to have ones which have the right level of assurance, not overly, but actually are completely safe, won't cause an information breach or a cyber security risk to the practice, where we result in a loss of patient data or anything else occurring. As a result of that, what we're having to do, and we're doing it very rapidly, is creating a list of suppliers and solutions that are safe for practice to use. And we're going to be publishing that imminently, which says these solutions have gone through an insurance process, are absolutely fine for practice to use.
I just put myself on me. That's excellent. Thank you. A few responses.
Nikki, can I just chip in? There's one question I just saw was whether extended hours appointments can be by telephone.
Yeah.
Yes, they absolutely can. In fact, they always could be. And the extended hours appointment should be subject to all of the same at distance, online and telephone type arrangements that we're suggesting more generally.
Lovely. Ed, your audio is a little bit crackly. That might be for others too, so just to repeat that, your extended appointments can be done remotely, hub appointments, etc. The answer to that question, because there's been a bit of a commentary on, we want it to be more specific, is come to local agreement. We're not saying that you have to do everything all the time, because we are not in normal times. I don't know what your specific scenario is, so speak to your commissioners. If you then need a national answer, let us know, because then we can develop that for you. There is a question or a point somewhere about the risk, the increased risk that telephone triage carries. So our regulators and the GMC have been saying really clearly that, and actually our data protection kind of officers as well have been saying, you are supported to make the decisions you have to make right now, because we are not in, we are not in normal circumstances. Okay. There's a question about the COVID home management service. What happened to this? We set this up, actually, it was, I know it doesn't feel like it, but it was almost 10, 12 days ago now, when we were still testing everybody and to manage positive cases in the community. The guidance last week meant that we've stopped testing everybody, so now everyone is presumed positive. So the home management service, in the way that it was instinctively created to support general practice and the patient, was no longer viable. So we've stepped that down so that the people that were already tied up offering that service are now available back to integrated urgent care and to yourselves. However, if locally, with your commissioners, you need that sort of specific management service or home management service, do develop that. And that's the point of the letter today, which is, please develop the solution that fits for you. Donald mentioned maintaining extended hours shows that we don't have an understanding of the nature of the crisis. Obviously I'm going to say that isn't the case. I think we're living and breathing it, pretty much 24/7. I think what we're trying to do is be permissive, because if we sit here always making the rules, that won't help everybody. But look, we can come out with some specific guidance on extended access if that's the easiest way to do this. Okay, we've still got time for more questions. Catherine, do you want to pick up some more? And Ed, if you keep looking as well, we can pick out more if we need to.
Yep, there's a recurring question about will practices and networks be reimbursed for additional costs they are incurring, such as overtime and locum fees?
Great. Ed, do you want to talk a bit more about that?
Yes, can you hear me better now, or is that just as bad?
It's better, good.
Okay, good. I will stand in the strange place I'm standing. We are having a discussion with the BMA about how we need to provide extra funding to practices and for what. I'm not in a position to say exactly what that looks like now, but I can definitely reassure that's in place. One of the things that I can see in the thread about extended hours is we've got lots of our staff in isolation at home. I guess I would just say, please do, as Nikki says, come up with innovative local ways, if you can, to use those staff to give remote consultations and appointments, and to sort of flex the way that extended hours is set up. I understand that everyone is. I understand that it's very difficult for everybody at the moment. Is that enough?
Yes, thank you. Still calls for us to make a national call on extended access, so let's take that away and come back to you, our webinar next week or in the interim, if that's okay. I
have another question for us, Nikki, if that's all right. How are we going to equip clinicians working remotely, particularly those who are returning to workforce who don't have any IT equipment?
So I can take that. So we're already looking at procuring solutions for them, either them being able to use the devices that they have or procuring devices for them which have the appropriate software on it so they can do that. So that's being managed centrally at this moment in time.
Thank you. There's a question about Med 3s. So obviously one can self-certify for 7 days, but that's sort of gone slightly out the window here. NHS 111 will be able to provide a digital verification of somebody having contact with them. There is no place that says, and in fact clearly on the Gov site it says that you do not need your GP to verify that you've had to self-isolate. And if you're going into extended isolation or shielding, we're working with the DWP to make sure that that can be verified without general practice having to do anything. And I'm sorry, yes, we do. It's been a little bit challenging to get the audio and everything right. There's lots of people now working remotely, even in the national team, for all sorts of reasons. And to keep them safe, we have had to do it slightly differently, but we will make sure there's a transcript available to you.
Nikki, it's Ed. There's a question about tax, and I might extend it to pension. So the question was about whether tax thresholds are being altered in order to allow people to be no worse off for doing extra work. And whilst we're all powerful, our remit doesn't extend to changing the tax system, but we have been part of discussions about changes to the pension system. You will have read in the 11th of March budget an announcement about changes to the annual allowance arrangements for next year, which I think should help some people. And there was a letter last week out from myself and our Director of Strategic Finance about a 1920 annual allowance arrangement to help people for whom that affects. So we are trying to do what we can to allow people to do as much work as they want to and not to face any issue as a result.
Thank you. Okay, Catherine, any sort of last few questions? I appreciate we've not got through all 800 questions. I'm still trying to scan and make sure that we can get as many as we can themes covered as possible, and we'll use them to inform the next webinar as we did with the last. So Catherine, any other things that you think we need to make sure we pick up?
Yep, there's one recurring one about what to do when patients are self-isolating because they or household members are sick, but they have intercurrent illness like a wound dressing, but don't have access to private transport.
Thank you. So, Ed, can you comment on that?
Thanks, Nikki. I think we are hoping to put some more guidance out this week on some of the scenarios and operating model that we suggest people might use in these scenarios. So we will hope to try and make some of that clearer then. The standard operating procedure talks about another set of scenarios that you might be able to sort of read and absorb and apply. I think it depends. It's hard for me to comment as a non-clinician and without, on a hypothetical scenario. But I guess if home visits are required, then we would suggest you follow the home visit guidance in the standard operating procedure, and which will be forthcoming, and use the PPE that's available where you consider that to be necessary according to the guidance.
Thank you.
Yeah, I'd agree with that, Ed. Yeah, so if someone's sorry, this is Amy coming back in. If someone, no worries. If someone's self-isolating for possible COVID and needs a home visit, then whether that's for COVID or for another problem, then you would need to use the PPE and follow the guidance as outlined in the SOP. Yeah.
Thank you. Lots of questions in caps about the new SOP and guidance on the scenario. So the new SOP is online. Is that right, Amy? On the website up there.
I'm not sure if the SOP is yet live on the website. I have been trying to find out.
Okay, so keep checking. It has gone into the process by which it gets on there. So please, it will be on there if it's not on there right now. And guidance in terms of specific scenarios, absolutely. And I'm hoping, I know our RCGP colleagues are working to develop that guidance. There's a question about reassuring you about what primary care will or will not be asked to do in the future, so pre-hospital triage or assessment. I suppose I have to move to some kind of core principles here. We're working really hard, and it might not feel like it, we're working really hard to look after general practice and to look after our population in a time that none of us have experienced before. We're trying to learn nationally and internationally about the best things to do. I couldn't have predicted a few weeks ago that primary care would look like this and work like this, and I think primary care is going to look very different in 1 week or in 1 month's time. We'll all be working differently again, and we can only use our international learning to try and understand. We want to keep you safe and we want to keep our patients safe, but we might all be working in very different ways. There is a question about Easter. I don't know. At the moment, the trajectory looks like it's going to be pretty bad over Easter, and if that is the case, then we are going to ask for help to look after our patients. And I hope that people are able to do that, maybe not at a practice level, but maybe at a network or group of networks level. And the best we can promise you is to keep talking to you and keep telling you what's happening and why we're heading in the way that we are. I think just to round up, look, there's clearly a lot happening. Every item we've talked about has had a whole piece of work behind it. We're trying hard to pick up the issues as they arise. Please do keep sort of feeding into us, whether you're doing it through social media, through your regions, and through your LMCs or your RCGP colleagues. We're using that to keep developing and refining what we do. We should then have some FAQs up so that we can capture what you've asked and what we think the right thing is. We're trying to do it right as much as we can. We won't get it right the first time, none of us will, so bear with us. We're trying to keep getting it right. I wanted to just mention, look, things like appraisal have been cancelled, but if you're struggling, you might find that you can still get in touch with your appraiser for some advice. The BMA GPC have a wellbeing service, and the practitioner health service is still running. It's hard times, but please rely on each other, please rely on those resources, and rely on the fact that we will do our best to help get you through this as well as we can. So thank you for your time. That's been an hour. We'll be back again this time next week with more updates. Please keep looking at the website when you can to make sure that you've got the up-to-date information, and we will get this webinar live as soon as we can. Thank you for your time. Thank you, colleagues, for joining me, and we shall speak again soon, no doubt. Thank you.
Thank you. That concludes your conference call for today. You may now disconnect. Thank you for joining and have a very good day.